Okay, Tracy, I think we're live, so over to you.
Thank you. So welcome everyone to the third session for abstract presentations at the Marie Curie Research Conference. So I'm Dr. Tracey McConnell. I lecture in palliative and end-of-life care at Queen's University Belfast, and I'll be chairing this session. So we'll be hearing from two speakers in this session on themes around inequities in end-of-life care, covering financial insecurity for terminally ill migrants, addressing intersectional inequalities in end-of-life care, and exclusion of people unable to consent to research. So I'm just realizing there's 3 items there, but unfortunately we only have 2 speakers today. So all of our speakers have submitted their corresponding abstracts to Marie Curie. So those can be found on the British Medical Journal, and Marie Curie colleagues will be posting links to those in the chat, so look out for those. And then a reminder that you should post questions in the chat during the presentation, and then they'll be discussed after in the Q&A section. So each presentation will be 10 minutes long. There'll be 5 minutes for Q&A at the end. So now I'd like to introduce our first speaker, Professor Liz Forbat. So Liz joins us from the University of Stirling. Her abstract is titled Financial Insecurity for Terminally Ill Migrants in the UK, Double Jeopardy at the End of Life. And the presentation will explore the complex issues facing these people and the policy and practice changes needed to address those. So over to you, Liz.
Great, thanks so much, Tracy. So this presentation is going to be mixing in some new ideas around migrants, along with some of the ideas that we're hearing about this morning around financial insecurity. I want you, before I start going with the actual study, I want you to imagine being in the UK and having no safety net here. You've got no family. I want you to imagine having to work through chemotherapy on a building site so that you maintain compliant with your visa so you don't get deported or removed from the country. I want you to imagine being in debt from NHS care and ongoing uncertainty about how much you'll be charged if you do use or continue to use the NHS. I want you to imagine being trafficked to the UK, working in a restaurant only to be evicted when you become too unwell to work, so you become street homeless with no visa status. These are the stories that we heard through our research, and these are the real lives of being lived by terminally ill migrants. So we started this research because we were interested in this very highly marginalised, double jeopardised group. There's really not very much research or understanding about this group. And we felt that given the multiple concerns that they live with in terms of being dependent on attending work or engaging with study because of their visa conditions, that the risk of financial insecurity for them was extraordinarily disproportionate. And if we think about some of the data from this morning about the likelihood of being in financial precarity for working age adults, that's basically the same group that we're looking at here, but with extra levels of jeopardy in terms of their migration status and the need to continue working or studying, even when really critically unwell. So the aims of the study were to really understand how people navigate employment issues and financial precarity in the face of terminal illness in the UK. We're interested in what we could learn from policy from all 4 UK countries around healthcare access, migration, and living with terminal conditions. We're interested in understanding how people balance paid and unpaid work alongside meeting the visa requirements, and thinking about what were the wider implications for family that might be resident in the UK or more widely internationally. And then how do we understand the health, social care, the legal services, the statutory and the voluntary sector about how they respond to and support this diasporic group with terminal illness. methods. So just one slide on methods here. So we have three components to the methods. So we were interested in doing some desk-based research. So we conducted a systematic review of literature on terminally ill migrants. We looked at a media analysis of UK print press media focused on the intersections of terminal illness and migrants. And then thirdly, we looked at a policy analysis that was looking at policies and parliamentary debates where they were talking about the immigration health surcharge, which is basically an extra levy which migrants on work and student visas have to pay in order to access some NHS services and so on. We also did some interviews. We aimed to recruit people with lived experience of this and were unable to recruit, and I can talk more about that if people are interested. We interviewed professional supports, so that was people like social workers, palliative care social workers, nurses, and so on. And then people working in policy and legal domains, so immigration lawyers, those kind of people. And wrapped around all of that was patient and public involvement and engagement. So we had, excuse me, a couple of people with lived experience of being terminally ill migrants joined the project team right from the conception of the study through to the end and engaging in dissemination and impact, drawing on their own lived experience and perspectives. So what do we find? Right, I'm going to zoom into this slide, so don't worry about how small it appears at the moment. But really what I'd like you to attend to is the fact that this is a maze. So not amazing, but a maze. And this is how it feels for people living at the intersections of migration and terminal illness, but also for people supporting those individuals. So it's intended as a metaphor to help us understand that. I'm going to start to just gently scroll into a bit of it. So we can kind of have a look at some of the findings. So our policy analysis, you see each of the bits of the methods are represented in their own section. So the policy analysis really showing that the UK palliative care policies talked very little about migration. There was definitely a framing of policy really just about demographic shift, generally people getting older, but almost nothing on the intersection, or nothing at all on the intersections, but very little really, other than sort of saying, oh, well, these other people have these certain characteristics that need special treatment, but there wasn't really any thoughtful integration of that. The policy analysis and migration, so the immigration health surcharge, you know, really coming across very strongly there about how difficult it was for people to be living with this kind of double taxation, if you like. They've paid for a visa and they're paying for the immigration health surcharge, and then many people we understood were also paying for some health services when they were in the UK. Our interviews, so financial precarity woven all of the way through it. You can see some of the examples here. So street homelessness, so sofa surfing as one of the responses to that, and needing to access services like Trussell to gain access to food banks. What we found was that people would talk a lot about the distinction between community and charity-based support, and how much people needed to lean into schools, charities, faith-based groups to gain access to help, because statutory services weren't able to provide what was needed. And so that very heavy use of those kind of supports means that there's nothing structurally or systemically woven in, which puts people at an even more vulnerable and disadvantaged state. We also heard about how vulnerable, oops, sorry, my mouse has got a life of its own, there we go. We also heard a lot about how people were struggling with visa changes, and that sometimes people were having to change visa status in order to accommodate no longer being able to work or study. And one case where somebody was in the UK on a work visa, but then was going to apply for asylum because that is free to do, rather than trying to renew or apply for a new work visa given their circumstances, and they couldn't afford the visa fee to do that. So if you think about how alarming the newspaper stories are about migrants and asylum figures, some of these asylum figures are people that actually have got no other option once they're in the UK to manage their visa status. So it's really complex stuff going on there. I'm going to zoom in, given that I've mentioned newspapers there, to some of the findings here. And really the only newspapers that covered this intersection were left-leaning. So The Guardian was one of the main news sources which was reporting on this area, and it was very much leaning into an idea about we must do something to help this group. This group is vulnerable. So that was really reassuring in some ways. And the systematic review reinforced everything that we'd found, but was an international one, so much less sort of specifically relevant to the UK, but definitely picking up that financial stresses are seen internationally for migrants. I'm going to click through just to give you a couple of quotes so you can read for yourself a little bit of the data. I'll read these out in case anyone doesn't have a very large screen or needs that support from an accessibility. So a hospice nurse told us, every time I go and see her, she doesn't ask me about pain relief. She doesn't ask me about things that are related to my job. She asks me things that she's worrying, like who's paying her rent. She keeps getting messages from the landlord to pay for the rent. So her first message to me is, how am I going to pay this? Will they put me out of the house? What will happen to my boys? This person had three young children. Palliative care social worker told us that one of their clients was so unwell that they were continuing to work while ill. They had to force him to leave because he was very unwell. He couldn't continue. But I think what it is, some of the work visas, you're tied to that employer. You can't switch employment, and your renewal of your visa is dependent on them. I've had meetings with patients who said, we can't continue this employment, unfortunately, and they can't get sick pay as well. So people are massively marginalised. Not just in life, but in death too. This next quote from a refugee support caseworker was talking about a woman who was really concerned that her children would then be moved into care and potentially separated after her death, and thinking about claiming asylum as one mitigation for managing family circumstances. So the concerns really for this group, should they earn money or should they rest? And frankly, a lot of them are having to earn money rather than being able to sit with the symptoms that they've got, which is obviously an enormous concern. Framing migrants as a drain on the NHS was pervasive in policy literature, but not in the rest of our data, which gives us a little bit of hope. So a few take-home messages for us, really. So we know this isn't a widely recognised group, so I guess this is a plea to keep these people in mind in your own practices, in your own services, in your own research, to be thinking about whether or not you're noticing them, whether or not there's ways of capturing the data when somebody is at this intersection, and what different kind of helps they might need. And then some other take-home messages really for other groups, which is around the need to develop a route map so that professionals get a better understanding about referral pathways. And that probably fits quite neatly with some of the presentations this morning about helping professionals, social workers in palliative care and elsewhere, to think about how do we route people into benefits and different support services that are available. And then a pressing need for the Home Office to adopt a more humanised approach, maybe even a kind of direct hotline for people that need an urgent change in status because of terminal illness. And we felt we were quite buoyed up by the media findings, and really would like to call on ministers to think about how they can lead, but we can all be part of a change in discourse toward a more humane and compassionate approach to this group. So just quick flash up of the contact details and so on. You will find me on Blue Sky under Liz Forbat, and welcome any questions. Thank you for listening. And Tracy, you're on mute. We can't hear you yet. No.
It's just very.
I have my mute off.
We can hear you very quietly, Tracy.
Not really.
No.
Try to turn my volume up here. Is that any better? No.
Liz, there's a question in the chat. I don't know if it's worth you getting on and answering that while we try and sort out the...
Sorry.
Okay, let me just go see if I can see the Q&A. Were there any specific barriers to getting people with lived experience involved? Oh my goodness, Poppy, thank you so much for that question. Oof. Yeah, so we tried, I think it was over 600 contacts, including people we knew, so this wasn't cold calling, to try and make contact with people with individual lived experience of this. What we were finding was that some organisations didn't keep data about this intersection, so they weren't really sure. So some palliative care services were a bit hesitant to say whether or not they knew anybody or had anyone that that was a migrant that with terminal illness, either currently or in the past, because we were interested in speaking to family members too post bereavement. What we learned from our PPI, our patient public involvement group, was that we knew that people would be very nervous about speaking to us, and we went to great lengths through our ethics approvals and through thinking about our recruitment processes, about reassuring people that there would be no consequences in terms of if we were to hear anything about people maybe doing undocumented work or anything else that they were needing to keep staying afloat. So we made that very clear in all of our recruitment material. But we were still left with this feeling that in a short-term project, i.e. one of less than 3 or 4 or 5 years, that actually the trust isn't there enough to build up so that everybody would feel really reassured that they would be safe talking to us, because these people are in such marginalised circumstances. You think about that undocumented worker that I mentioned at the beginning, who had been trafficked to the UK, had told the Red Cross worker that they didn't want to take any legal or police action about what it would mean for them to contact a bunch of faceless academics in some university. So I think, you know, despite literally hundreds and hundreds of requests from the research team and building up relationships with them over, I would say, of course, about 18 months, some a bit longer, there just wasn't sufficient trust. We know the people are out there, because when we looked at the number of people that our interviewees did talk about, I mean, the number was really quite large. And I'd be interested to know if people in the room have got their own professional experience of supporting people in this group.
I just wanted to check now that I've rejoined.
I can see Tracy's lips moving, but no sound coming. So I'm hoping Luke, our IT expert's going to help.
Yeah, we can. Charlotte, do you mind contacting Jack, and then I will just continue to chair if that's okay. Tracy, is it just the way your microphone's positioned? Because I know before it was...
I'm not sure. I'm sitting...
Oh, there we go. We've got you back.
You can hear me? Oh, thank goodness. I left and rejoined, so maybe that did something. That seems to be the default. But sorry, Liz, so you had kind of put it out to those on the session if they wanted to come back to you.
Yeah, just I guess it's a general curiosity about, you know, how many people does this affect, and what a practitioner's experiences of meeting people in this position, because we know that we don't talk about them very much, but that we know that these individuals are out there.
Yeah, and please use the chat function. And then, oh great, we have someone there, Kathleen. So St. Francis Hospice have experience of this issue, but that's in the Republic of Ireland context. Thank you so much, Kathleen. So that's St. Francis Hospice.
Yeah, interesting. And it does feel very much as this is an international issue. There's no reason to think that the UK would be very different. But looking at the data, it's incredibly hard to actually get a proper estimate. So unlike some of the presenters earlier today who've got this big data and kind of linked data sets, what we're having to do is do a kind of home-stitched version of a Venn diagram where we think about who's accessing the DS 1500 or the SR1, what's the number and epidemiology of migrants, who's of working age, and within that Venn diagram, we've got really only a best guess about how many people fall into that at any one time.
Thanks so much, Liz. And I can see now that we're actually at the time to move on. So just to say thank you again. I thought it was really powerful at the start of the presentation, Liz, where you actually asked us to think what it was like for migrants. And I think that was probably the most powerful part of the presentation, and definitely something that will stay on my mind when thinking about this area. So again, thank you so much. So unfortunately, our second speaker, Jamila Hussain, can no longer join us today. But just to give you an overview of what Jamila was going to talk about. So Jamila is a consultant in palliative care from Bradford Teaching Hospital, NHS Foundation Trust, and would have been presenting her work on the end-of-life experiences of people from intersectionally marginalised groups and how community researchers are really key in enabling inclusion of these individuals in end-of-life care research. So you can still read up on Jamila's work from the abstract titled Community Researchers in End-of-Life Care Research, Addressing Intersectional Inequalities, a rapid realist review and evaluation of the why, the how, for whom, and in what circumstances. So we're now moving on to our final abstract for this session, and I'd like to welcome Dr. Caroline Barry, who is based at the Norfolk and Norwich University Hospital, NHS Foundation Trust, and the University of East Anglia. So the abstract we're going to hear about now is titled Understanding the Scale of Exclusion for People Unable to Consent to Research Towards the End of Life. And this is a scoping review. So looking at why those with impaired mental capacity, which is prevalent at the end of life, may be overlooked as participants for relevant research studies, and how barriers in doing so might be addressed. So really looking forward to this one. Over to you, Caroline.
Thank you, Tracy. I'll just check we've got the IT going. We good. Can everyone see the right screen? Can you give me a thumbs up, Tracy, if we're good?
Yep.
Perfect. All right. Thank you, everybody. So yes, as Tracy said, I'm here to present on behalf of our project team, which includes Martin Patel, Clara Yates, Claire Rishmiller, and Guy Perrier. And this is around understanding, I suppose, the challenges or the scale of exclusion for people who are unable to provide consent to research in an end-of-life context. I want to acknowledge, first of all, the NHS England Research Engagement Network, who funded this project and continue to fund this project, and also the NHR Applied Research Collaboration of the East of England, who support me and are also supporting this project. So just a little bit of context about the Research Engagement Network. This is a programme that's been running for a couple of years now by NHS England, part funded by the Department of Health. And its overall aim is to increase the diversity of people who participate in research in one way or another, and specifically looking at underserved or marginalised groups in that. So there's been a broad range of projects looking at, children's access to cancer trials, asylum communities in Cambridge and Peterborough, even down the road from me in Great Yarmouth, looking at circus performers, and all of their the programmes tend to start from the point of view of understanding what the health needs of that community are, and then building opportunities for research around that health offer, in the recognition that actually research participation, or the choice to be offered participation in research, is something that ought to be stitched in to everybody's experience of the NHS. And for the purposes of our project, the mental capacity piece, it was really what we wanted to do was understand what structural barriers there were to participation. So not framing it around the challenges that the individuals might face, but actually what are the barriers that perhaps we put up, research institutions, clinical settings that inhibit participation. But I suppose it's important to acknowledge, first of all, that we're not looking for blanket inclusion in this group any more than we're looking for blanket exclusion. So this is important concept in research, as we know, that really a basic premise is that people ought to be able to choose whether or not they participate. And if someone hasn't got that decision-making ability, it's important that we don't override that without justification. So we see this in the Declaration of Helsinki, which makes it clear that a condition of the research ought to be that we're studying something that's affecting the capacity. It ought to be about the capacity affecting condition. So a good example might be the fact that, dementia research, which in some cases may be characterised by a diminishing mental capacity, is something that's going to be studied. We understand that there needs to be a sensitive and meticulous balance of risk and benefit for the individual. And also that in some form there's likely to be some sort of decision-making proxy or supported decision-making process that needs to happen. When we apply this to an English and Welsh context, and I appreciate that we've already got more than England and Wales represented on the people on this call today, but just in this is my setting, we've got two significant legal regulatory frameworks that we operate under, and actually the difference accounted for as to whether or not the trial or the study involves a medicinal product. But even within these two frameworks, within England and Wales, we've got significant differences, both in terms of what the proxy decision maker might look like, what the standard or the type of consent is used, how a person with impaired capacity is treated if they lose it during the study procedure, and finally the ethical justification. So, already in just a sort of couple of minutes of explaining, you can see it's not a straightforward context to be conducting research in. When we looked at other disciplines, so other disciplines where impaired mental capacity is common, we see the experience of researchers is that they don't love navigating this process. So it's been described as the black box of horrendousness in some studies. And that's put down to, as I've mentioned, the complex legal framework, the fact that often the populations with a high prevalence of impaired capacity or communication challenges, that there are what can be perceived as gatekeepers because of a perceived vulnerability of the group, both in terms of a clinical setting, but also perhaps at the research ethics standard, where you're having to justify your involvement with this population. There's been an acknowledged lack of training to help researchers navigate this framework and these challenges, and a recognition that it adds a lot of time to already lengthy processes. So as a starting point for our project, what we really wanted to do was understand to what extent the challenges that are observed in other disciplines around the inclusion of people with impaired capacity in research is evident in a palliative and end-of-life care context. And what we wanted to do was sort of quantify that in some ways, and we use the NIHR portfolio, which is sort of keeping track of studies that are supported by what used to be the clinical research networks, are actually have inclusion criteria which allow for the participation of people with impaired capacity. And we adopted that scoping review methodology really in acknowledgement of the fact that there isn't a lot out there around this already, and we wanted to sort of identify future research questions and areas of exploration. So we looked at 1,959 studies. After removing duplicates, we got that down to about 1,750 studies. And rather than just looking at palliative and end-of-life care studies as they were badged on the portfolio, we also went into dementia and ageing and a care home setting in recognition that they were areas where there may well be a high prevalence of people approaching end of life, and there may well be studies in that context that were relevant to the question. And the second thing we did was sort of narrow it down to the past 5 years, because what we wanted to do was, where necessary, contact other investigators to flesh out a bit more information about whether people with impaired capacity had been included, and we felt that the past 5 years would be a reasonable timeframe to capture the memories, if you like. And we were left with 150 studies for analysis, 14 from ageing, 5 from care home, 22 from dementia, 14 from hospice, and 105 from palliative care. And although actually it's not a sort of relevant outcome for this study, it was just interesting to us that actually, there were 911 dementia studies on the portfolio. Only 22 of those were relevant to palliative end of life care. So we narrowed down quite a lot. So I guess the headline figures is that certainly from a palliative and end of life point of view, the vast majority of studies didn't cater for the inclusion of people with impaired capacity. Once we get into ageing, care home and dementia, the inclusion rates were higher. So it was 21% overall across all the studies. But actually, of the ageing, care home and dementia studies, most of those weren't actually relevant for palliative end-of-life care. So we do see that only really a very small proportion of those palliative care studies allowed for recruitment of people with impaired capacity. We then went on to have a number of stakeholder conversations around the people involved in the studies to find out more, to check we'd gathered the right information from the portfolio, and just to sort of sense check our findings. And we heard many stories around palliative care specific challenges, around recruiting and designing studies for this group, a sense that perhaps palliative care maybe goes for the low-hanging fruit sometimes in our research, and actually these are really difficult studies to put together and get approvals, and we just don't have the infrastructure necessary to actually deliver on them a lot of the time. We heard around the uncertain legal landscape, but also on the more positive side of things, and something that you see, I think, throughout inclusion work is the importance of those relationships, those community advocates, and the role of the voluntary sector in helping navigating some of that complexity. So sort of summary really was only 5% of palliative care studies include people with impaired capacity. And I think it's important to acknowledge that a sort of limitation of the study is that we didn't then go into each individual paper and say, well, actually, was the exclusion justified? Could the research question have been answered without the inclusion of people with impaired capacity? And I think that's certainly a valid limitation to think about. But I suppose the other side of it would be if we think about how prevalent impaired capacity is in our population, particularly during the dying process, and only 1 in 20 of our portfolio studies are concerned with examining that part of the pathway of someone in end of life. What is it about the research that we're doing that isn't asking questions that are particularly relevant to that population? And the other thing that was really significant was that even when the trials that we'd seen on the portfolio had gone through and been published as papers, even when they did include people with impaired capacity, there was a complete lack of reporting around the proportion of people who were unable to consent for themselves had been included. It wasn't clear where a consultee had been used or a proxy decision maker had been used. Was that a personal consultee or was that a professional consultee? So it doesn't seem to be the framework around reporting to help us understand exactly what the scales are. So in conclusion, I think we can say from our work that the exclusion of people with impaired capacity from research that is found in other disciplines, such as has been seen in intellectual disabilities, can be observed in the palliative care population. We've got ongoing work with the Research Engagement Network to try and address some of these systemic barriers to inclusion. So this is part of a much bigger project, which has got a number of arms to it. One thing we're really particularly keen to understand is what authentic ethical participatory engagement looks like in this space, and particularly how proxies, advocates, and other third parties can be used to support ethical involvement. And part of that will involve the development of a competency-based module to help support people sort of bridge that knowledge and skills gap that they're reporting. And there's my blue sky, link in my email address if anyone wants to follow up. Your sound is a bit tricky again, Tracy, for me. I don't know if it is for others.
Tracy, if you it might be best, can you hear me?
Yes.
It might be best to just leave and rejoin again. I'm not sure why it seems to be when you mute and unmute.
Yeah.
Thank you. In the meantime, I'd just like to encourage everyone watching to just put some questions in the chat for Caroline. We've got a little bit of extra time today, so yeah, feel free to ask any more questions. And we've got one here. So can you tell us a bit more about the ongoing work you're doing with NHS England Research Engagement?
Yeah, sure. So, as I said, this is one. The scoping review was actually the first 6 months of the project, which ended last April, and then that was about identifying what the barriers to inclusion were and developing some key recommendations to take it forward. So the recommendations that we identified was around, firstly, around research relationships and developing trusted therapeutic relationships that would be able to discuss research opportunities in a sort of more of an ethical context, because what we were hearing was that people were reluctant to start conversations around research participation towards the end of life. People had impaired capacity, it was seen as too burdensome. So we've partnered with the Motor Neurone Disease Association, who've got a £5 million research nursing programme that they're launching over the next year. So the idea is that we will train the research nurses that are coming on board to have greater knowledge around the use of the provisions of the Mental Capacity Act and research provisions, but also around how to initiate those conversations about research in a bit more of a sensitive context. So we've developed a conversation guide and a visual summary of the report, and to help sort of break down some of those challenges. The other thing we're doing is that it's a bit small print, but one of the particular challenges in this space is that when you need a third party, when you need a decision-making proxy, a consultee, as it's called under the Mental Capacity Act in England and Wales, or if that person isn't available, so if you're unbefriended, normally in health, we would use an IMCA, an independent mental capacity advocate, to help that decision-making process, and those of us who work in clinical practice will be familiar with that. Now, there is provision for a similar sort of role under the Mental Capacity Act, the nominated consultee role, but actually it's not defined at all about what that person should be. There was a code of practice and there was some Department of Health guidance that's been archived, it's 8 years out of date. So there's a real knowledge gap around how that role should be performed. So our finding was that actually there's a potential for third sector and voluntary organisations to fill that space, for it to be more of an advocacy role for people, particularly for people who are socially isolated. So we're currently doing a systematic review looking at how proxies could be supported more, and how they can support to address the inclusion gap. So that's the second bit. And then the third bit is the module development I spoke about. So taking guidance on mental capacity law broadly, mental capacity research, lots around actually accessibility and support decision making, because obviously where possible we want to support people to make decisions for themselves. And then finally a sort of consultee module, so that if we're asking someone, either a carer or a professional, to take on that consultee role on behalf of someone else, that they've got a resource they can go to feel more supported in that decision.
Great, just checking, is my volume working again? Can everyone hear me? Perfect. So look, if you can share the Q&A with me again, it seems to have disappeared from
Yeah, I've taken off the questions.
Not sure if you can see, are there more Q&A?
I've taken off the questions that have been answered. I don't know if anyone else has got any questions. Tracy, have you got any questions yourself? Oh, we've got one from Charlotte here. Yeah, so we received the following question. Do you know if, actually, sorry, Tracy, we can hear you now, I'll let you read it out. Yeah,
sorry, is it in the chat there?
I can see that, yeah, sorry, I don't know if it's helpful. I'm just aware we've got Liz on the call, so the question's about whether or not there's differences in Scotland. There are differences in Scotland. My understanding is that if anything, the situation's more complex and challenging in Scotland, but I don't know if Liz is able to speak to that, if she's still...
Yeah, still here. Yeah, I would not position myself as being authoritative enough to respond to that. But, yeah.
Oh, sorry. Yeah. So sorry. Yeah. No, I don't know why I got in my head that I'd spoken to Liz about it. Sorry to put you on the spot there. Yes, there is a difference in Scotland, and I think it's now, don't quote me on this, but I think that you actually have to be sort of legally appointed as a representative in Scotland. So I did speak to people in Scotland as part of this project, and I heard that it was even more of a challenge, if anything, in Scotland, because at least in England and Wales, when you appoint a consultee, it's kind of you can do that without any sort of legalistic process. It's just part of the study design. Whereas, as I say, my understanding from the conversations in Scotland was there was an extra layer of bureaucracy that made it even more challenging.
Thank you so much, Caroline. And I don't see any more questions there in the chat, so if we're happy to finish there, just to say thank you again so much to your speakers. I mean, it's been really informative. I feel like I have learned so much as well. And there's more links there in the chat for you to find out more about the different projects, and just to thank you both for doing such amazing work in this area. I mean, in terms of the Marie Curie vision to improve end-of-life care for all, I mean, you're totally pioneering in that field, so thank you so much. But that's us at the end of this session. So I have provided sincere thanks, and just to thank those who have shown up for the session, and to remind you that you can access more abstracts as posters in the platform poster booth area. So if you have any further questions that you would like to be answered, please do connect with the speakers. You can use the networking functions on the platform, or you can email Marie Curie team at research.info@mariecurie.org.uk. So just to say thank you so much to everyone. I hope you enjoy the other sessions, and that's us bringing this one to a close. Thank you.